All right, so my name is Stuart Swadron. Nice to meet you. You guys are the best. There's 3 courses every year. This is the first one. And you guys invariably are the most prepared and smartest because you're on top of your game. I like how the audiences change as they get towards the actual examination. The third group is, it's a lot of fun. It's raucous. They're unprepared. They're panicked. They haven't set enough of time aside, so you can rest assured that you're the responsible ones. How many people here are doing their, it looks like mostly research. How many people, you look old. How many people are doing the test for the first time? Okay, there's a few here. Anyone else? No one on this side? You guys have you have to reassure these folks. You have to tell them it's going to be okay and life is going to go on. And I don't know what you guys can tell these people. You're going to make money, everything's going to be okay, you're not going to get an EMTALA violation. Make them feel better because they're just getting into this business. Anyway, so nephrology and urology is easily the most interesting topic because you're all really like it. You all wanted to go into internal medicine, but you didn't get in, right? So you had to do emergency medicine residency? All right. Well, let me tell you something about this section is roughly broken up into 2 halves. The first half is nephrology, the medicine half, and the second half is the surgical half, the urology half, which I think that for us, being the kind of, here and now baby cow, get it done type people that we are, we tend to be a little bit better at that. So when it comes to the first half, the renal failure half, I have good news for you. How many people here are confused about renal physiology? Electrolytes, renal failure. How many? So there's a couple of honest people, a lot of liars. Come on, give me a break, right? Okay, this is the good news. The folks at ABEM that do the exam, that set the exam, they don't have a clue about it either. So what that means is that they're going to stick to fairly classic. They're not going to give you subtle, difficult renal cases. They're going to stick to very classic examples of the main syndromes, and you're going to get the questions all right. And what I've done for you, if you take a look here, I think it's the first 15 or so slides, is a very, talk to me like I'm a 6th grader type, break it down in the simplest terms approach to renal failure. I think it's going to serve you. I think it's going to serve you well for the test. I also think if you're a lot of people who are involved in teaching, also a good way to teach your residents and to break things down for other people that you're teaching. So everyone knows this diagram here, okay? Pre-renal, renal, post-renal. Everyone knows that. I'm going to highlight different areas in there as we go through and talk about what you need to know at each of those stages. Now, the easiest one is pre-renal. And the way to remember that is to, and I'm not going to make anyone repeat anything out loud because I know this is a serious, studious bunch here. It's not, you don't want hijinks. But just in your mind, say to yourself, pre-renal failure equals shock. Not a person in this room who doesn't know what shock is because, of course, we treat it every shift we ever work. We are seeing patients with shock. Pre-renal failure is just a synonym for shock. Full stop. The kidney is not seeing enough volume of blood. And you know the causes of shock, and you know the treatments of shock. I don't need to tell you that. Fluids, and in some cases pressors, relieving obstruction, whatever the cause of shock is. Okay, so that's really, really simple. And of course, we're responsible for it. I mean, can you imagine calling up a renal consultant and saying, oh, I've got this patient, the creatinine is 3, and then you explaining that the blood pressure is 50, and they're going to be like, okay, well, maybe you should resuscitate the patient, then we'll talk, okay, that type of thing. So we're totally responsible for pre-renal failure. It's our job. It's not a diagnosis that should ever be made by anyone but us, initially. The hardest segment is the middle part, the renal failure, okay? And that's the part that really screws people up. That's the intrinsic disease in the kidneys themselves. You can see them outlined. And what I'm going to do is I'm going to take you from where the blood actually gets into the kidney to the point where the urine exits the kidney, and it's going to go through 4 steps. And each of those 4 steps, something can go wrong. I'm going to identify what the problem is, and we're going to know the classic example of that type of intrinsic renal failure. So let's start with vascular causes. This is often very straightforward on a test. Sometimes it throws us for a loop clinically, actually, and people don't realize what's going on. But let's just say you have a patient who has renal failure. They're not peeing, their creatinine is high. If there's anything else in that question or in that patient that indicates another organ is failing, so we have a problem with the liver, we have a problem with the brain, like a stroke, we have a heart attack, we have a leg that's cold and pulseless and white, those are all indicating that there's two objects along the big red tube that have malfunctioned, the kidney plus something else. And that's supposed to always make us think of the aorta. And the things that go wrong with the aorta, generally speaking, are major things, right? Anything that says aortic on your diagnosis usually is really bad. And so we're totally 100% responsible for that, whether it's a dissection or a AAA or embolization that's coming from the calcified aortic root. That's what we're supposed to think of. So I think that's kind of a no-brainer for us, and we're going to get those. Now it gets a little more complicated because you actually have to go into the kidney, and it's complicated in there, but let me make it very simple. See the outline part on the slide there? That's the Bowman's capsule, that's the glomerulus, okay? And that's where the filtering of the blood happens. Now, the one disease that we're supposed to know the best, the one that always comes up on examinations, is the nephritic syndrome, acute nephritic syndrome, which is really a synonym for rapid progressive glomerulonephritis, okay? Now, this is the way I think about it. Just think of that, the blood is getting filtered through that convoluted structure there, okay, the glomerulus. And what happens is in immune diseases, and the classic one is post-streptococcal glomerulonephritis, okay? And so you're already thinking about that question in your head. It's usually going to be a kid. They're usually going to have had a strep infection. They might have had a strep throat. They might have had any type of strep infection in their body. And then a few weeks later, they're going to start showing symptoms. And what are the symptoms going to be? What happens is that glomerulus, if you will, gets all bunged up, all plugged up. It gets plugged up by immune complexes and by actual clots of blood, cells of red cell cast accumulate there and spill off into the urine. And it doesn't let the fluid out. It doesn't let the fluid be filtered. So what ends up happening is you have a patient who gets fluid overloaded, and they get swollen. And what happens when you have too much fluid coursing through your vessels? You get hypertensive. And of course, since none of that blood is getting filtered, there's no urine. So when you see a patient who's not making urine, they're edematous, and their blood pressure is high, and typically on exams they're going to use that example of the kid with post-strep glomerulonephritis, you've got your diagnosis. The urine is just icing on the cake. And what's the urine going to have? It's going to be filled with red cell cast. The treatment is not totally under our domain, but at least we have to recognize this. These patients are going to get inpatient treatment. Usually they're going to get a consult and steroids. Okay, now moving from the glomerulus, let's say the fluid has in fact filtered properly through the glomerulus. It then has to get, as you know, reabsorbed in the tubules, okay? And that area where it gets reabsorbed is called the interstitium. That's where you have a gradient of concentration that ends up making the urine the right dilution for that patient's volume status. And the most important disease that I want you to know, and the one that will come up most frequently on the examinations, is basically like an allergic reaction. It's called acute interstitial nephritis. You'll see this with antibiotics very commonly. Penicillin and sulfur are the two most common. It also happens with NSAIDs. And really, the way I want you to remember this one is it's kind of like an allergy. They have low-grade fever sometimes. They have a rash. That sounds very allergic. And eosinophils. They're going to have eosinophils, and they're going to have them in their blood, and they're going to have them in their urine. So it's kind of like an allergic reaction to the drug that's causing a renal allergy, if you will. And of course, the treatment is stop it. I'm going to call a nephrologist, of course. I'm going to say, you know, do I need to use anything else? They might recommend other treatments. They might need to be admitted. They might need to be dialyzed. But important thing is to recognize that diagnosis. So that's not too hard. This is our final stop. We've had 4 stops in the kidney, and this is our final stop. The last place that the urine filters through is the tubule, the renal tubule. And if you haven't identified a cause up until now by sort of thinking of those first 3 steps, or first 4 steps, this is probably where it's going to be, because acute tubular necrosis is the most common cause of intrinsic renal failure. That's a question that comes up all the time on examinations. It's kind of the garbage bag diagnosis if nothing else seems to be fitting. I want to tell you something interesting about this. There are 2 types, and everyone in this room has seen this, and I think everyone in this room has probably diagnosed this. There's the kind where they make a lot of pee, and there's the kind where they don't make any pee. Okay, oliguric and non-oliguric. And it's very simple to know which one is which. Most of the cases of ATN that we see are in two groups of patients. They're in trauma patients. They go into hemorrhagic shock. So they start off as pre-renal failure. And then after time, the kidneys start dying. Okay? And pre-renal failure then turns into acute tubular necrosis. It's ischemia because it's not getting enough perfusion. That happens in trauma. And of course, it also happens the same way in sepsis, right? They go hypovolemic. They're not perfusing their kidney. There's not enough fluid in the system that's going through. It's all third spaced. And again, they go into pre-renal failure followed by intrinsic ATN. So those are the classic things, and we see those. Those are probably 90% of all the cases. And they're going to be oligemic. There's no urine because there was no blood going into the kidney. There was nothing to make it from. In all the other types of diseases that we learn about, I call them the exotic things, the toxicology things, the special drug reactions. You see I've listed them here, ethylene glycol, multiple myeloma. These are disease states where there's actually damage to the tubules. There's some sort of toxic reaction going on. There's nothing wrong with the amount of blood that's filtering that's coming into the kidneys. Their perfusion's okay. They're not in shock. They don't start off as pre-renal failure. But this poison, be it aminoglycoside, be it a toxic alcohol, this poison is actually directly screwing with the tubule. Okay? And in that case, they have renal failure just the same, but the kind where there's enough urine. It's just that the urine doesn't contain the right things. Okay? They're not properly filtering their toxins. So if you're making a lot of urine with ATN, it's from one of these toxic mechanisms usually. Okay? And that's probably the minority, maybe 5 or 10% of all the cases of ATN. One of the causes of ATN that we will get lots of questions on, it's hard to imagine a board exam without questions on rhabdomyolysis. It's hard to imagine. It's one of the causes of ATN that we see more often than others that we're supposed to be experts in. And I want to say, that's why I want to say a few more words about it. Now, we all know that rhabdo is caused, the kidney failure that you get in rhabdo, we're specifically talking about the kidney aspects of it, is caused by myoglobin basically plugging up and damaging the tubules. Just at a simple level, that's how I think about it. So you might ask yourself, well, why is it that we don't just measure myoglobin? And for those of most of the people in this room are used to measuring myoglobin for rule-out MI protocols, and we all know how useless it is, right? It goes up in every case. A nurse gives a shot of morphine, and all of a sudden the myoglobin is elevated. We don't know if it's from the heart or it's just not a reliable thing. It's very spurious. And in some cases, the kidneys can be completely plugged up with myoglobin from rhabdo, and because they're all plugged up, there's no myoglobin in the urine. So the reason why we don't use myoglobin, which is the actual problem, is because it's unreliable. It's unreliable and inconsistent. That's why we use CK. It's not that CK is what kills the kidneys, it's just because CK is reliably elevated in the blood of people who have rhabdo.